My name is Bart Scott. I am at the Fred Hutch. I've been here for 25 years. We run a investigative portfolio for MDS and MPN. I have several of my colleagues here with me today that I'll introduce throughout the session. There are some corporate remarks that I wanted to introduce to you. Before I do that, though, I want to thank the Plastic Anemia and MDS Society for helping us organize this, in particular, Lee Clark, who you met on the outside there. Yes. And then internally, Joan Vermeulen, who has actually set up all of the patient meetings to date. And now we have Rosalind Pierce, who may be here as well. She was out front. She helped organize the conference internally. And I want to thank both of them because they worked very tirelessly. And I know that all of the people who put their slides together, all of the speakers, they organized their travel for them and helped them get their slides in on time. All right, now for the corporate remarks, we have Joel Hastings from Alexion. If Joel, you want to come up, thank you.
Thank you very much, Dr. Scott. It really is my pleasure to be here today. My name is Joel Hastings, and I'm Director of Patient Advocacy at Alexion. Alexion is the rare disease group of AstraZeneca, and we research and manufacture medicines for the treatment of rare diseases. We have 6 medicines treating 7 different rare diseases. Our very first treatment was in PNH in 2007. And ever since then, we've been working with the Aplastic Anemia and MDS International Foundation. It really is our pleasure to be a part of that and collaborate with them. And it's patient conferences like these that are so critically important to the overall trajectory of how patients live and manage these diseases. And I'd say today is a very bright day for patients because of all the activity and work happening here. It really is our pleasure to be a part of this. So thank you very much, Dr. Scott.
Thank you. And then from Novartis, we have Jason.
Thank you, Dr. Scott. Hello, good morning, everybody. My name is Jason Kuo, and on behalf of the PNH team and Novartis, I want to thank you all for the opportunity to be here and to learn from all of you. At Novartis, there's a couple of things that are so important. The first one is about science, using science to develop transformative medications for serious diseases. The second thing that's very important at Novartis is listening to patients, listening to caregivers, family, and loved ones of these diseases, understanding what's important, what are the different needs that all of you have, and you guys are the experts here. So I very much look forward to today, learning from Dr. Scott, other faculty members, learning from all of you about what's important in these diseases. So I just want to end by thanking AMDS and the faculty, Fred Hutch, for the opportunity to be here. Thank you.
Okay, now we're ready to begin the lectures. There'll be time to answer questions or ask questions after the presentations, and also there'll be breakout sessions as well. So hopefully the slides will come up fairly soon, or maybe we need to pull them up. Okay, great. Thank you. So the first section is, what is my diagnosis? And many of you in the audience have PNH or MDS or aplastic anemia or myeloproliferative neoplasms. And you may wonder how these diseases are related and unrelated. And I think it's always good to begin with this, because without knowing what you have, of course, it's hard to know what the best treatment options are available to you. So all of these are considered to be marrow failure disorders. And essentially, your bone marrow is where your stem cells are, and they make all the components in your blood. And there's 3 major components in your blood. The red blood cells, which are the erythrocytes that give your body energy. They help to carry oxygen. And then there's megakaryocytes, which make platelets. That helps to prevent bleeding and bruising. And then all of these other cells in here that you see are what we call white blood cells, and they help you to fight off infection. And what happens in these disorders is that there's some issue or problem within the bone marrow itself, and you either make too many of these cells or too few of these cells, and you end up having clinical problems from that. All of these diseases are related to one another, and there can frequently be overlap between them. So one is aplastic anemia. That's a marrow failure disorder where you don't make enough cells. Dr. Keel in the audience will be speaking about that. PNH is paroxysmal nocturnal hemoglobinuria. That's a disorder where you destroy your red blood cells. It has a lot of associations with both MDS and aplastic anemia. It can also present with marrow failure. Aplastic anemia can start off as aplastic anemia and go into PNH, and aplastic anemia can go into MDS or AML. So some of you may have noted, wait a minute, I've had more than one of these, and that's because there can be overlap and progression between these different states. MDS stands for myelodysplastic syndrome. That's essentially a disorder where you don't make enough cells and your blood counts are low. There's a risk of progression to acute myeloid leukemia for all of these disorders, which is a cancer in the marrow. We have Dr. Halpern, who will be speaking about how these diseases can progress into leukemia. And then we have myeloproliferative neoplasms. That's essentially a disorder where you make too many cells, and Dr. Halpern will also be speaking about that disorder. There are some commonalities between all of them. First, they're rare diseases. So one of the things that I frequently encourage patients to do is to seek out an expert within this field at least once, someone who can guide the overall management of your disease. Many of my patients live in far-off places. We have a fairly large catchment area in the state of Washington. We have Washington, Wyoming, Alaska, Montana, Idaho. I have patients from Hawaii. I even have international patients. And of course, I can't see them day to day or week to week or month to month, but I can see them maybe on a yearly basis every 6 months and be involved peripherally. Most major academic centers do have experts in this. And because they're so rare, another component of what we do is we review the outside morphology and bone marrows that have been done to help really define what the diagnosis is. And it's not uncommon that, you know, it's thought that they might have one of these disorders, but in truth, they have another. So I do encourage patients to try to seek out expert care at least once during their course because these diseases are so rare. The other thing they share in common is increased inflammation. So that can cause a lot of the symptomatology. They have disorders in the bone marrow microenvironment. So they're not able to process cells correctly. And all of these disorders have this propensity to go into acute myeloid leukemia. With MDS, this is how we think patients get this, is that they develop a mutation. MDS, for the most part, is thought to be an acquired disorder, not something that you inherit for the most part. Dr. Keel is going to be speaking about how this can be inherited. So there are some forms of bone marrow failure disorders that can be inherited, but for the most part is an acquired disease. We think that environmental exposure is a big component of this, but you develop a problem within the bone marrow, one of the stem cells become mutated and then grows over time. There's about 9,700 new cases per year. It's more common than acute myeloid leukemia. The median overall survival is about 2 to 3 years. We do have prognostic algorithms. This is one of them. It's not the most recent one, but the survival can vary anywhere from 0.8 years to 8.8 years, depending on which prognostic category you fit into. Median age is 72. It is more common in men than women, and that may be because of increased environmental exposure risk. There may be other factors. The incidence does increase with age. That's probably because of exposure risk, but there may be other issues like stem cell exhaustion. The stem cells get old just as everything else does, and they're more likely to develop mutational abnormalities as they age. Aplastic anemia is a bone marrow failure disorder where you don't make enough cells. It can be congenital, which Dr. Keel will be reviewing. It can also be acquired. So you have some illness or some exposure, typically what we believe is to some infectious agent that activates your immune system, and your own immune system can start attacking your stem cells, which leads to low blood counts. The incidence is about 2 per million in the West. It is higher in Asia for poorly understood reasons, 2 to 3 times higher. There tends to be a triphasic presentation very early, young in age, which we believe is more inherited, and then in the 20s, and then in the older age group. This is the survival curve of patients surviving with aplastic anemia and actuarial survival of 292 patients. This is from a while ago, and we have improved our treatments over time, and I do believe the survival is better for aplastic anemia currently. Paroxysmal nocturnal hemoglobinuria is an acquired disorder. It's not something that you're born with. And essentially what happens is you get a mutation that occurs on the X chromosome that interferes with a gene that we call the PIGA gene. And the PIGA gene makes a protein that binds CD55 and CD59 to the surface of your red cell. I'll go into this more when I give my talk, but the important thing to know is that this is acquired. You're not born with it. And because the CD55 and CD59 are missing, you destroy your own red cells. This is an actuarial survival table compared to age and gender match controls, but this was taken before the approval of complement inhibitors. So it's important to know that this survival curve doesn't reflect our current treatments available. And with the advent of complement inhibitor therapy, which I'll go into, the survival of patients with PNH is similar to age and gender matched controls. So we really have been able to improve the outcome of patients with PNH. So the 5-year mortality of 35% is no longer true. Median age is around 32. There are quality of life issues. There's a risk of going into AML. And on the positive side, there's about a 15% spontaneous remission rate. So patients can spontaneously go into remission if they have PNH. Myeloproliferative neoplasms have some type of driver mutation, and there's 3 basic types that we call the BCR-ABL negative myeloid neoplasms, which is what this conference focuses on, because there's separate conferences for CML, which is a BCR-ABL positive myeloid proliferative neoplasm. The most common mutation that you see in MPNs is JAK2V617F. Dr. Halpern will be going through this in more detail, but the important point is that you acquire some mutation in your stem cells that leads to proliferation of these stem cells. And all of these different disorders have upregulation of what's called the JAK-STAT pathway. The other mutations that you can see are called calreticulin, here CalR, and MIPL, but the most common one is JAK2V617F. This is a very old paper from 1951, but so insightful from Dr. Damashek. He's a very renowned hematologist. We have a prize that's given out every year in honor of his name, but he wrote a paper way back in 1951, noting that from a clinical perspective, that all of these disorders, they had different names back then, but it was essentially ET, MF, and PV. He noted that they were all closely interrelated disorders that represented proliferative activity, and he theorized that there was probably some uncharacterized stimulus that led to this way back in 1951 without understanding any of this molecular pathogenesis. And now we know what that stimulus is, and it's these mutations that leads to upregulation of this JAK-STAT pathway. When you look at the survival in general for MPNs, the best one is ET and then PV, which you see here in kind of the blue curve, and the worst survival is seen for patients with primary myelofibrosis. Survival has improved over the years. This is just to 2008, looking at different age groups, but no matter what age group you were in, survival has gotten better. And this is looking specifically at patients with primary myelofibrosis, comparing the 80s, 1980 to 1995 to 1996 and 2007, just showing that we have gotten better in the treatment of myelofibrosis. When I first started in this business, there was no such thing as JAK inhibitor therapy, which of course we have now, and it's commonly a treatment that patients receive. This is looking at the age distribution of these bone marrow failure disorders. Median age of diagnosis of PNH is around 32. The risk of MPN increases with age as it does with MDS. And I mentioned to you that aplastic anemia has a triphasic presentation, very young, and then in the 20s, and then as you age. And the differential age presentation is different from Western European countries and Asian countries. This is just one small study that showed this, but in Asian countries, aplastic anemia tends to present in earlier age groups, whereas in Western European countries, it tends to present in older age groups. Okay. One of the things that happened recently is that there were actually two different classification systems that were developed for myeloid malignancies. This slide does not reflect that. I'll just say that right now. And there's the WHO, and then there's the International Consensus Classification, or ICC. Typically, before this, we only had mostly one classification, the WHO. But now there's two, and so there's basically two different ways that one could diagnose MDS and MPN. And I think it's fair to say that as academic centers, we're still trying to sort through that, which brings me back to the point that I made earlier. I think it's very important that if you have one of these rare diseases that you are seen by some expert at least one point in time, just to make sure that the diagnosis was made correctly and that you're on the correct treatment. But in general, for MDS, myelodysplastic syndrome, you can diagnose that based on the presence of morphologic dysplasia, which is abnormal growth in the marrow. You can make that diagnosis based on karyotype, which you see here with the different types of karyotypes that one could potentially make the diagnosis of MDS. Or you can make that diagnosis on the basis of increased blast count, typically greater than 5% in the bone marrow or 2% in the blood. Or you can now make that diagnosis based on what we call mutational abnormalities, which is a relatively new thing that you're probably going to hear more about, which you're going to hear about now. So this is a slide showing what we call cancer genomics. And I think from a patient perspective, it's good to have some minimal understanding of what this means. But you have your cancer cells. And by the way, most of these disorders are a type of cancer. MDS and MPN and AML certainly are. PNH and aplastic anemia are not typically thought to be cancers, but rather marrow failure disorders. But regardless of whether you say that it's a cancer or not, these cells from these marrow failure disorders have in them frequently chromosomal abnormalities. And so here we have on the chromosome level, and you can have breakages or tears in these chromosomes. And so when we see a patient with marrow failure, one of the studies that we would want on their bone marrow is called a chromosomal analysis, sometimes called a karyotype, sometimes called a chromosomal genomic array test, sometimes called fluorescent immunofluorescence, FISH testing. But all of these look at chromosomal abnormalities. We also look at what's called genetic abnormalities or gene abnormalities or mutational abnormalities. And that's really at a much smaller level where you can look at single amino acid mutations. So if you are a patient, when we consider your diagnosis and your prognosis, it's very important for experts in the field to have that information about chromosomes and mutations to try to figure out not only what your disease is, but also what your prognosis is. Some of these I'm going to skip, but this is just one example of how mutations can be important in MDS. So all of these that are listed in red here are mutations that are associated with a worse prognosis. And from a patient's perspective, honestly, it's probably not so important that you get into the weeds of which mutations are good or bad, but rather just to know that that does affect your prognosis. And the green ones here are felt to be good risk mutations that carry a better prognosis. That has led to a new prognostic algorithm for MDS called the IPSSM. It's very complex and complicated. It's not something you can do in your head. You basically have to use a computer algorithm to figure it out, but it divides your disease into different risk categories. And Dr. Caraway will be going into more detail about how we treat MDS patients and how this might be important in determining which treatments are best for you. For aplastic anemia, we determine prognosis based on the level of marrow cellularity and also the degree to which your blood counts are low. And you can see different survival probabilities on the basis of whether you have moderate, severe, or very severe aplastic anemia. For PNH, we base prognosis on whether or not you have an associated bone marrow failure disorder. As I mentioned, PNH can overlap with both aplastic anemia and with MDS. And if you have classical PNH, historically, that had the worst survival. But now, this is before the approval of terminal complement inhibitors, but now this has really been reversed. The survival is now worse for patients who have bone marrow failure disorders associated with their PNH, and the best survival is seen with classical PNH. MPNs, I mentioned to you that we're really focusing on PV, ET, and myelofibrosis. There's these BCR-ABL positive MPNs called CML, which is not part of this conference because they're treated in a completely different way. Dr. Halpin will be speaking about the treatment of MPNs. I mentioned to you already about how Dr. Damashek way back in 1951 theorized that there was some type of proliferative activity, and this is what this slide is showing. Activation of the JAK-STAT pathway leads to the underlying pathophysiology of patients with myeloproliferative neoplasms. This is the WHO classification before 2022. I mentioned to you that a new one came out in 2022, but there hasn't been much change in that. When we experts try to figure out which one of these you have, it's very important to look at the blood counts and also at the bone marrow itself, because without a bone marrow, it would be impossible to distinguish between myelofibrosis, for instance, or prefibrotic myelofibrosis, and some of the other myeloproliferative neoplasms. In regards to prognosis for MPNs, most of it is driven by your age and whether or not you've had a prior thrombotic risk. And based upon those two factors, we decide whether or not you need additional treatments to help prevent blood clots. And blood clots are the chief issue that patients with polycythemia vera and essential thrombocytosis face. This was a nice retrospective, actually prospective analysis of patients with polycythemia vera and how they do over time. And there was a 4-year mortality of greater than 10% in patients with polycythemia vera. This was a relatively recent study, so it does reflect some of our treatments. 1/3 of the mortality events were due to blood clots. So blood clots are still an issue in patients with MPNs, and more than 25% had uncontrolled proliferation. So many patients treated with MPNs, despite being on medical management, are still not well controlled. This is a current prognostic model that we have for myelofibrosis. I think one of the important things here is this molecular subtype. So again, we have a disease where molecular mutations are an important component of prognosis. So when you see your doctor and you want to know what your prognosis is, it's important to have that information, what the molecular profile looks like. When it regards to how patients present, sometimes patients are asymptomatic. They just go in and they have a CBC done, and it was a routine blood count, and their doctor says, you know, your blood counts are off. And I was like, well, I feel just fine. You know, I don't have any problems at all. From a medical perspective, we call that asymptomatic presentation. Sometimes patients will come in with issues related to their blood work. Paradoxically, when the platelet count is extremely high, you can have bleeding issues. When the blood counts are low, like with the white count, you can have infections. And when your red counts are low, you can have severe fatigue. And then if your blood counts are really high, you can get blood clots, like if your hemoglobin or hematocrit is too high. You can have itching, you can have gout, and you can have burning pain and skin redness, which we call erythromelalgia. For PNH, the most frequent symptoms that patients have is actually fatigue. You see 96% of patients with PNH have fatigue, but it's extreme fatigue. typically out of proportion to their degree of anemia. When we see patients with these disorders, we work them up for other potential causes like vitamin deficiencies. We do blood work test of note, the CBC, and of course, we want to do a bone marrow. Most of these diseases do require a bone marrow. There are some exceptions, like with PNH, that's diagnosed off what we call flow cytometry of the peripheral blood, which is what this is talking about. So we do that on the peripheral blood flow cytometry. We discussed some of this. But I'm going to conclude by saying that the bone marrow failure disorders are difficult to diagnose, and there's a lot of overlap between them. The clinical and diagnostic studies are imprecise, and many of these entities overlap. And I've had patients who started off as having PV, who then ultimately develop ET, and then who progress to myelofibrosis. I've had patients who start with aplastic anemia and then develop MDS, or go on to have leukemia. And I've had patients who start with aplastic anemia who then come in with PNH. So that's why these diseases are kind of grouped together, because there is this possibility to transition between them. Cytogenetic testing is considered standard of care, and I would say that molecular testing is now considered to be standard of care as well. So we do want to see that testing performed on patients. So with that, I believe we do have about 5 minutes for any questions. There may be a method for virtual questions to come through, but if there is, I'm not sure what it is, but I think one of our AE people can help with that. But any questions in the audience that you would like to ask? There's a microphone here and I can bring it to you, or Dr. Halpern can do that. Thank you, Anna. If there's any questions in the audience. And feel free, if you're thinking about it, probably your colleagues are too. Well, let me ask a question, just to get a sense. How many patients do we have with aplastic anemia here? Okay. And how about patients with PNH? How many PNH patients? See, some of you are raising your hand more than once because you can have both. How many patients have polycythemia vera or central thrombocytosis? Anybody with those? Okay. And how many patients do we have with myelofibrosis? Okay, and not to leave out another one, how about MDS? Any patients with myelodysplastic syndrome or MDS? Yes. Okay, see? And you may have noticed that some people are raising their hands multiple times. Okay. Any further questions that people can think of? How about my scientific colleagues? Any questions that you wanted to ask that you might think would be relevant for the patients to hear? Okay. We have a patient question, then we'll come to Dr. Caraway.
I was just wondering, how do you know when you move from one to the other?
Very difficult, honestly. And sometimes even the experts aren't sure. But when a patient's disease changes in a significant way, I mean, and I can give you an example, which I think commonly happens. Say you've had a polycythemia vera patient who's been on either interferon or hydroxyurea for a long period of time, and their blood counts have looked really good. And then they come in with a big spleen, like they have a lot of abdominal discomfort, and now all of a sudden their blood counts are too low. That is a potential sign of progression to myelofibrosis, and we would want to repeat your bone marrow, in particular a bone marrow biopsy, to look to see if you have that scar tissue. So the general answer to your question is there's some change in their blood work or some change in the patient's symptoms that says to the treating physician, hey, something might have happened here. Now, it's not always. Sometimes people can get viral infections or something like that. But it is a signal to say, well, maybe we need to look again if you see a change in your blood work or a change in your symptom profile. Dr. Caraway?
You talked about mutations. How do you know that you have or haven't been tested for that? And if not, like, what do you ask for?
Yes. So if it's hard to figure out if you have been tested for that, honestly, from a patient perspective. So I advise you to ask your treating physician, hey, have you checked to see if what my mutational profile is? And if not, then you would say, I want to have my mutational profile checked. I will say it's very difficult from a patient perspective because we use different words for this. Sometimes we use a term called whole genome sequencing. Sometimes we use a term called next generation sequencing. Sometimes we use a term called hotspot. But if you just say, what is my mutational profile? I think that's going to get the message across. Is that what you would suggest? Okay.
So I had a question. After these mutations happen and or a spontaneous remission, is there any research being done to look at, what were some of the factors for these patients who moved from one to the other, or those who did have a remission to like help patients understand what to do, what to avoid, if they don't want to switch?
Yes. So to answer your first question, is there any research to understand how patients transition from one of these diseases to the other? There absolutely is. It's a very active area of investigation, and we do have increased understanding of how that happens in some of these disease processes. One frequent way that these diseases changes from one state to another, like for example, MDS going into leukemia or polycythemia vera going into myelofibrosis, is that patients acquire new mutational abnormalities within the cancer cells themselves. So the disease can progress over time. So for an MDS patient, you could start off with maybe something like a TET2 mutation. And then you have kind of a lower risk disease, your blood counts aren't that bad, and maybe a watch and wait approach is taken. But then you acquire an additional mutation, like say like an ASXL1 mutation, and that's known to have a worse prognosis. And with that, your disease changes and you progress more into a leukemia phase. So it's not always that, but frequently there is some type of disease progression. Now for the spontaneous remission, that's really applicable to PNH, not necessarily to the other disorders, although it has been reported, I know, in some other patients. But with PNH, you would notice a change in your blood work, and you would notice a change in some of the other things that we check, like LDH, and you would also notice a change in what we call the clone size. So we do intermittently check patients' clone size with PNH. And as I said, there's a 15% reported historical spontaneous remission rate. And if you had one of those spontaneous remissions, then you could potentially discontinue complement inhibitor therapy. Okay. Well, yes, another question from the audience. I'll repeat it. Okay, so if a patient has a mutation, can it go back to normal? And the answer is yes. So we do give treatments for all of these variety of disorders, and some of the treatments that we give are designed to really target the cancer cell itself. So for example, patients treated with interferon-based approaches who have PV or ET or MF, for instance, can have molecular remissions where the JAK2 mutation is not present any longer. Now, there's a big debate, and only time will tell if this is ultimately what we would consider to be curative, but about 1/3 of patients do progress. I mean, 1/3 of patients do develop a remission, but
You off the stage.
but about 1/3 of patients who are treated with an interferon-based approach can develop a complete molecular remission. And of course, patients who undergo allogeneic transplantation, which is the only curative intervention for many of these diseases, we would hope their mutational abnormalities go away. And there's other examples, like for MDS, patients treated with induction chemotherapy or with hypomethylating agents can develop what we call a complete remission with no minimal residual disease, where their molecular mutations can go away. So to answer your question, yes, they can go away, particularly with targeted therapy.